Welcome to Health System CIO's interview with Dr. Melek Somai, VP and Chief Technology and Product Officer at Inception Health, which is the innovation arm of Froedtert ThedaCare. I'm Anthony Guerra, founder and editor-in-chief. Malik, thanks for joining me.
Thanks, Anthony, for the invitation.
All right, looking forward to having a fun chat. I know you're speaking at the upcoming Chime Fall Forum down in San Antonio, over in San Antonio. Your session is entitled Access to Impact, Making Virtual First Care Work Long Term. So looking forward to having a fun chat with you now about that topic and exploring it a little bit for folks that are either going to pop into your session or for those that won't be at the show, just to help them explore the topic a little bit. So, um, tell me about why you selected this topic. Obviously, I assume it's a big part of what you're doing in your daily work. Um, you could be working on a million things. Everybody could be working on a million things. Every IT department could be focused on many things. This is obviously something you are focused on in your organization. Why is that?
No, it's a very important question to ask the why. And I think this is something I see most often is we in the technology space sometimes like focus too much on the technology aspect, but the technology is really not the most important piece. And I think in healthcare, what we often say to our within our ecosystem and our colleagues is that technology is the business in healthcare. And what I mean is technology is a tool and capability to drive outcomes. And for that reason, the way we thought about why digital first primary care or digital technology is important is we needed technology to contribute to the transformation of the healthcare system operations.
Hmm.
And one of the reasons is we are an academic medical center and community-based care system in the Wisconsin area. We serve the community uh, around 10 million individuals in our community. We provide care, but the most important things we are aware of is that we have a lot of conundrums happening at the same time. We have external challenges. We have patients now have more premiums, and it's growing and increasing with high deductible health plan and others, which means that the share of care burned by an employee or an individual, a patient, is getting higher. And that
Hmm.
means patients are not getting access and avoiding access in many circumstances. We also have internal challenges. Our internal challenges is the care we provide today, even though we are providing quality care service. The challenge we face is that we have a very challenge with our own providers. I give an example in the state of Wisconsin. Over the next decade, 40% of the primary care providers who operate today will retire.
Hmm.
And we do not have enough physicians trained to provide the care we need. Other challenges is actually the care cost is continually growing. And if you consider a healthcare system today, margins are extremely slim. So how to find what is the operating model that we need to find to be able to scale the care, provide better access to our patients and our community, and at the same time, decrease in cost. We believe, at least one of the hypotheses we have here, is that technology should be the driver of that scale and economy. So there is no way we can train enough individuals. There is not enough to add more individuals because that associated with cost, training time, and all of that. So how we solve this problem now and how we solve it for the future. And one of the interesting aspects we decided to take on is we need to be moving forward and reaching the patient where they are using technology and focusing on two primary things, focusing on access. So that is one. So how we can provide access, better access to our patients, which means anytime, anywhere at their convenience. And second, how we provide it in a way that is convenient for them. And this is
Hmm.
where technology plays a role. So the decision we took was literally taking a model where technology is the front door of the healthcare service delivery. And what we build behind the infrastructure, meaning people, clinicians, team members on engineering team, IT, and other colleagues to kind of create the infrastructure to deliver that service. And
Hmm.
this is different from traditional IT work in a traditional healthcare system where we are mostly working in the back office. So most of the time, we have the healthcare system being the front, trading with the patient, and then we have IT providing support in this way, it's actually the way around, where technology is the driver of that innovation, and actually the clinical team and other members are supporting that model to operate. And I can dive into more details why that is needed. Like one of the key aspects we believe in is that this is urgent and is absolutely required. The current technology infrastructure we have doesn't offer us the capabilities to be operating in that business model. And that's going to require us time to learn how we operate in that ecosystem. Like traditionally, healthcare systems are not known to be consumer friendly. Access is difficult, and this is important. Like we are, like most of the research we did, Anthony, showed that patients trust us. Like we have like one of the highest trusted brand in our community. But the most difficult thing, people believe that we need to do better to make it ourselves accessible. So that is kind of the conundrum we're trying to achieve by combining both a trusted healthcare system with a platform that can provide that consumer-centric. And consumer-centric is not a word that we use often in healthcare, but that's kind of what we're trying to drive.
Very good. Very good. So as you were talking, the one thing came to mind. I remember this issue coming up a lot when we talked about scheduling apps and things like that. And you talk about bringing technology to the front and sort of operations supporting. The challenge that can come with that, and you tell me how this plays out on the ground, is there are many technology tools and applications that can be turned on, can work, can be implemented, but the problem can happen when the operational workflows and the individuals that have to then execute with those new tools haven't changed the way they operate, right? So we can put lots of technology over the surface, which might be thought of as the technology first approach, but there's so much on the back end, the human part, the messy part, the workflow part. Nobody wants to change any. Change is so hard. Minor change is so hard. So it's just that's to me as you're talking, that's a big challenge here. I'd like you to talk about that issue.
Oh yeah, Anthony, let me give you an anecdote. So we did have a lot of innovative startups, innovative companies coming and saying, let us fix the scheduling, and we have a much better experience for scheduling for patients than what you have today. And when you do actually root cause analysis, what you realize is actually the problem is not the scheduling experience, is that we do not have enough physicians to schedule for. So if you're a patient, no matter what experience we could provide, if you cannot book an appointment because your provider is only available in the next 18 months, like that doesn't improve. Like it doesn't really matter. So what you realize is, I think this anecdote think about airline companies, like they're doing an amazing job. We pick airline companies as a really good example of how technology has improved consumer experience for airline company. Like getting to an airplane is not a great experience, but they made it with a digital experience very fluid. And the idea is that we need to provide you what you expect from us as a service, meaning also access. So getting to your point about scheduling, what you realize then that if technology can build that consumer grade experience and behind it there is no process to be able to deliver on the expectation of the consumer, then what you realize is that we build the wrong process and we build the wrong architecture. So that is kind of the part where we say it's a digital first experience. What we did was then we need to operate technology, but technology drives the process. And for us in digital health platform, and this is probably unique, I would say, there are a few healthcare systems who are actually going into this process where we moved into a product mindset. And what I mean by product mindset is that building the experience also means building the process. So for us in this digital first primary care model, the team that we have that operates this program is a combination of engineers, clinical informaticians, but also care providers. The care providers are part of the team, and they build both the clinical process and the technology component. And this is important. We did not build the technology and launched it within our current primary care model. We know that that's going to require a very change of process. I give you another example, like when we tried first virtual care. And the challenge was that providers were very confused. their cognitive load was very high. You want me to see a patient in the office now, and then you want me to go to another room to start a chat and have put my headphones and put my camera, and then I need to go back to then meet another patient in another physical place to meet them. Like the process doesn't work. Like this doesn't help me. I'm losing time. I'm losing cognitive load. I have to log in here. I have to go here. That doesn't work. So what we need is reimagine that workflow. And for our case, what we did was making the clinical team part of our product development. And the way we say is we develop a product to the patient that includes the technology, the process, the care experience, the care delivery model itself. So you might argue this is one of the challenge here that we could discuss about is then how do you scale this model? Because this model is almost like brand new model. It's almost an incubation of a different approach of how to provide care. The challenge is going to be, can you distribute this at scale now across our entire ecosystem? And that's the challenge we are trying to deal with now. But that's the promise is you are absolutely right. Technology in and of itself has no value. The beauty of technology, it allows us to think differently about the ability for us to launch a process. Before, we needed to build a wall to preach you. Now, what we think, what about building technology that offers us a different way of interacting with you? So this is kind of the aspect that we are very interested in. We have a really good research group that also help us think through these aspects of what is that experience that we need to deliver to patients and how we make it an entire product.
Well, I love this. I mean, I think it's brilliant. As you said, it's a great in concept. It's just the execution question. You need a lot of bandwidth, right, to do these things you need. Because as you said, the problem is trying to layer new technologies onto existing workflows, processes, and things like that. And it sometimes it doesn't work. So what you're saying is we're not going to do that. We're going to have sort of innovation incubators and places that we can layer technology on top of new workflows. So we're going to change the workflows in these areas as we have sort of parallel, like this health system's operating, everything's operating over here as it was, but over here we're trying new technologies on new processes, and we've got everyone together who needs to be involved in the team that's going to make this happen. It's a product mindset over a project mindset, right? Project mindset is there's a beginning and an end. This is more of a product that continually evolves.
Right.
So that makes a lot of sense. Anything else you want to add there? Otherwise, I'd like you to touch more on something that I find fascinating as a discussion, the concept of cognitive load, and how that's probably it should come up everywhere for IT leaders in everything they do. The cognitive load that you are introducing, there's change management. It's a direct connection between change. By definition, if you change something, even though you're hoping to ultimately reduce cognitive load, you're going to have a spike in cognitive load no matter what you do, or no matter how much you're going to lower it on the back end. And you have to be very thoughtful about that. And if you don't consider that significantly enough, you're going to get into big trouble, right?
Absolutely. And we use few heuristics. I mean, I can share a few of the heuristics we do in our clinical work. One of the heuristics we use is make the right thing easy. Like make the right thing the default and the easiest path forward. I think that was one, and we try to force that as much as possible. Make the right decision being the easiest one to make.
Mm-hmm.
And I take the example of preventive care visits. We're trying to work around mental health for our patients. One of the programs we launched where you can self-enroll into an ICBT program for you as a patient. And the idea started with this idea: why are we making people enrolling in the program being, for instance, requiring a visit with a provider? Why is that? And we said, like,
Mm-hmm.
why do we need that? Why we know that's the right thing.
Right.
So how we make the right thing the easiest thing possible?
Right.
And it's one click away. And
Yeah.
that was like some of the programs. What we do too, also from our clinical side, we actually trying to build interfaces that facilitate for you to make the right thing. So one of the aspects we trying to experiment now with AI and large language models is, can we actually assist the provider as they interact with the patient to figure out the right protocol and assist them? It is not trying to add more information, it's trying to assist them. And we think very thoroughly about what type of information we surface. Like there are so many interesting aspects. Like we tried initially when we build large language models to provide patients protocols to the provider. Providers like, I know this. Like, I don't need to see this again. Like,
Mm-hmm.
don't bother me with the surface. I want to actually treat the patient. So you see this like elasticity of what we do and how we do it. The other thing from our former mentor Warner Slack has this idea of, if you build technology in healthcare, the value of the technology is the inverse of the number of the size of the documentation you build for someone to use it.
Right.
It has
Right.
to be. Providers are not to promote, like, change management has to be easy. So how we make it such that it's the normal behavior of change. So those kind of
Yeah.
the
Go
aspects.
ahead. Go ahead.
And yeah, and one of the things I will add, that leads us to actually part of our team. We have UX and UI researchers, and their role is to make things the easiest accessible to our patients. So it's not only building the technology. And I know, until like, this is like, how come a healthcare system is investing in this? I think the way we think about it, like, this is important for us because we are the organization accountable of providing care to the patient by the end of the day. And our role was, we either buy, we either partner, and if those two do not lead us to the right outcome, we will take the accountability to build.
Mm-hmm.
So I think this is another item we can discuss about, is like, why do we need to be a builder of technology and products in the healthcare, as a healthcare system today in the industry? And that's a very difficult one. Is that our role? Like, every dollar we spend on our patients need to be spent on our patients. So how do we make sure that that investment that we do for building actually derives the right outcome? And that's kind of one of the biggest challenge I see in most of the healthcare system. We don't have enough elasticity in our capital to take on experiments. So how we do the right thing and how we innovate, that's a very, like, there is a fine line there. And that's something that we try to always drive. We say building for us is not something we like to do. It's something that we truly believe is critical for us to be delivering the outcome. And that's a very important exercise we do all the time.
Yeah, it's really interesting. Dr. Peter Pronovost, University Hospitals. He's very well known. I interviewed him recently. He just had an article it's actually featured in our e-newsletter this week about venture philanthropy. It's this concept of raising money uh, and promising a return on it to the donations you're getting, and he's matching up this influx of capital with specific pilots and projects, and trying to show major return. So you're trying to not just get donations, but tie those back to major returns. I thought of that when you were talking about having the resources to experiment and innovate, um, when you feel you need to build something. When you can't find it, you feel it's very important. We can't find it, we can't buy it, we can't partner, we want to build it, it's expensive. What are some different models we can do that? Well, this made me think of that venture philanthropy type thing.
Yeah, yeah. And on our side, I mean, again, the way we consider this, like, it's a very small size of investment for our healthcare system to do this innovation, and
Mm-hmm.
and the results, and we are always driven by results. So our reason for continuing and iterating is the ability for us to deliver value to patients by the end of the day. And this is something also very important. Like, most of the healthcare systems consider IT as a cost center. It's like, it's a spending to maintain ability to deliver care. So it's a cost entry. On our side, where we deliver all of the investment we make for our innovation, we consider actually from a different angle. It has to deliver outcomes, and it has to be directly related to outcomes. So it's more of actually not a cost center, it's actually a care delivery center. We're trying to invest in money so we can deliver care, and that has to have a return on outcomes. So it's a very different operating model if you think about it. And it leads us to having skin in the game, so to speak. By
Mm-hmm.
the end of the day, we are accountable for the right outcome. So even though if we do the right thing technologically, if it doesn't deliver the value and the outcomes, it means we failed.
Yeah, Dr. Zafar Chowdhury over at Seattle Children's spoke to him recently, and he said something very impactful about a complete reframing of ROI around healthcare investments. We were talking about ambient AI, the discussion was about, and he just said this whole thing has to change about, the idea of implement a technology. Well, where do I cost cut now? Like, where's the direct tie to cost cutting? He said that's got to change. A lot of this is stakes to play now. And there's other ROI around, as you said, physician satisfaction, patient care, and all these kind of things. So He just thought that whole model of ROI in IT spending had to change. Sounds like you agree.
Absolutely.
Yeah.
Absolutely. Absolutely. I mean, I think absolutely. And the main reason is technology has to become core to our healthcare infrastructure. Like the way to think about it is I do not believe that without technology, we will be able to bend the curve of cost and bend the curve of access at the same time. Like there is no other model that can actually allow us to scale. So unless we build technology as like first principle, which means it has to deliver that outcome and drive on that,
Mm-hmm.
having that reasoning of a project man, like what you really mentioned, Anthony, areas like project versus product,
Mm-hmm.
change the entire equation.
Mm-hmm. There's a lot of major shifts happening right now in healthcare. I mean, currently, as I'm speaking to people like yourself, there's new thinking and different thinking, major changes in approaches going on at the moment, driven by all the things you mentioned, all the drivers, empowered by technology, where really the biggest change there is the generative AI, which is kind of supercharging a lot of tools. Is that a way to
Absolutely.
think of it? Is that sort of a major inflection point right now?
I think we are living like an amazing inflection point. Like this is for me representative of probably the 70s and the 80s when relational database were created, and then we have enterprise softwares. Like that for me, like the enterprise software era is the one that led us to build the EHR. So I see this is another inflection point, and I see it's an inflection. It's one of those moments where it is going to be the right time. Like we all the different um, vectors are combined together. It's we are all aware that we need to provide much more scalable, accessible care service. We all know this. We also know that our cost today is not sustainable as an entire ecosystem. We also, our patients require us to be more driven. And at the same time, technology, generative AI are going to allow us to totally rethink the technology stack and make it much more easier. Like there is this kind of wave where it is the right moment, all the tides are coming all together, and that's going to be a multiplier effect. I think generative AI, I'm very bullish on our generative AI promises in healthcare. I think that's going to be transformative. The challenge is probably not the generative AI, it's actually us being able to absorb that and being able
Yeah.
to deploy it in the right way. So this is the moment where we need to do that investment as individual and as communities and also as an entire ecosystem. I don't believe that one healthcare system can do this by itself. Like has to be a community driven. And to your point, like there are buckets of a lot of work being done. So does that create enough momentum? That's the question. I mean, I am always thinking about scale in healthcare is difficult because we are very regional and localized. So
Uh-huh.
how do you
Yeah.
actually grow that technology? Because there is no value if you keep it localized.
Huh. Yep. Yep. Lots of good stuff there. As you were talking, I drew a little diagram here. Um, and I was thinking, what are some of like the nexus points here, the connection points? So we have all this technology, amazing technology, and we still have this thing over here called the human brain, right? And the human brain, it can bang up against all this technology and collapse. The whole thing collapses. This is cognitive load, right? So let's take the human brain I'm thinking of, which is the physician, right? I mean, yeah, we have nurses, we have clinicians, but let's simplify this. We have the physician brain, the human brain evolved, millions and millions and billions of years, depending on how far you want to go back. And all this stuff still has to meet that brain. That brain hasn't changed. So, the brain's still the brain. And this is where we talk about cognitive load. This is where we talk about informatics, right? This is
Yes,
informatics is all this cool stuff meets the human brain. And how do we get
absolutely.
those things to work together? And so that's one connection point, right? And then, so we have to figure that out. And then we have two human brains connecting in a physician patient encounter, right? So human brain with technology, human brain, two human brains connecting. So that's just what I was thinking that
Yeah.
all this
And I will
that's got
add,
to work. Go ahead.
one thing. So you mentioned that. And I will add one element where I think technology will be valuable. There is also the patient being the driver. I mean, there is, Warren Slack said it before, is the least utilized resources and the most available resource in healthcare is actually the patient. So if you think about it, how we can also empower that with the support of the care system. So the traditional face-to-face interaction between a patient and a provider is very valuable. Like that is the most important and probably the most rewarding like experience. Like treating a patient and having that interaction is very important. But at the same time, how you make that the most valuable and how you can actually offload a lot of the experience you could be run by a patient. So I think there is another idea where technology could help the patients be more proactive and be actually part of the care experience. And that's kind of another angle we're trying to think about where AI can play a role, where it could become an advocate of the patient within the care system. Think about it as a technology driver, and it kind of help shape those decisions. And to your point, limiting the cognitive load of the patient and the provider so both can actually focus on what is the most important to them. Like think about managing preventive care visits. Like 40% of the patients today visits in primary care are around preventive care visits. Like how can we remove that cognitive load? Because we have the protocols, it's well established. We have home delivery of care kits that could be around preventive care. So we think about like this kind of experiences where you deliver more value to the patient and at the same time it's scalable and leave that interaction with the patient and a provider at the most valuable, the most critical aspects that you need to treat. That is kind of the aspect we're thinking about, how we entangle, how we make less of that experience and how we can make much more valuable. I think that's kind of one of the aspects I think technology could help a lot. So rather than having to speak about 80 different items in a 23 minutes visit, how we can make that visit actually really focusing on the most important things that the patient and the provider care about and let all the other things be managed easily. So I think those are the aspects. The other aspects is how we can make access convenient. One of the strategy we build in our digital first primary care is this idea of 24/7. And the idea of 24/7 is what if primary care service is not anymore one physician to one patient? What if it's actually an entire support mechanism? And it's when you treat, you come to a product that delivers you primary care. And that allows us for us first to provide you care anytime, anywhere. It provides us to scale and it provides us the ability to actually route. So now the cognitive load we discussed about, what if we can actually serve the patients for very different needs and route them directly, not having to go through a gatekeeper being a primary care to get to a specialist, or like how we can that routing to be more intelligent. I think that's another area where we see a lot of value. How we can make the primary care like a quarterback, so to speak, in a team,
Yeah.
and let that technology drive. So there are a lot of conversations here. I know, Anthony, we have very short time, but
No, it's great.
it's
It's great.
it is
Yeah.
this is the type of conversation that we must always think about. Like we have been thinking about this all the time. Like clinical informatics, to your point, was born in the 1960s and the 1950s. So those are not new constructs. I think just the technology and the time has made them more mature and more capable today of delivering the value. Like back in the 1960s, it was a 16-bit computer to actually try new things. And now we have massive capabilities in the technology space to be able to deliver on that promise and try to think again, what is the value we're trying to deliver through technology?
Yeah. I hear you. I'd like your thoughts on one issue. Um, it has to do with the disconnect between the direction we're trying to take things uh, in any type of customer service encounter. And I can't understand. Am I the only person that really dislikes automated phone trees and bots and things like that? So this is why it's breaking my brain. So let me give you a short example, and then you can go. I'm not surprised that generative AI and ambient listening is very effective. I use ChatGPT all day long. All day long. I love it. I use it now. I think I've gotten pretty good at using it what it's good for, at understanding its weaknesses. I'm right. I'm pretty good understanding this tool. I could see other people who use it, I think, a little clumsily. Call it AI slop, right? It's like I know it. I could see it. I could spot it. I know the keywords. I know the tells. Like in poker, you got to tell. Okay, but I'm not shocked that this is through the roof. In my personal life, in everybody I know, I see nothing but frustration with a lot of these other things, these automated encounters people try and give them. What's going on? And how do you avoid that as a health system? How do you avoid rolling out stuff and saying, look at all this stuff we put in, and people like me are on the other end going, talk to a representative, talk to a representative.
Yeah. Anthony, I will go back to one thing. This is what I said at one point in our decision thinking of what to do is we today, most of the time, we have to build. So I go back to this is we are still in this early reshaping of technology stack. We spent the last 15 years implementing AHR in healthcare system. We invested heavily in building the AHRs and building the configuration and building the processes. So this time frame where a new technology comes in, there is this, I would consider like there is this like vacuum space where the first movers are going to be the wrong ones because the first movers are going to take on what currently exists and they just stack up anything. Like it could be generative AI, it could be a new, like it could be anything, and they will just stack it up because the market says, oh, we need to react. So I would say we are more reactionary and we're trying like to find the nice thing that can add a little bit, but it doesn't change much. And to your point, it actually adds more complexity. Right? It doesn't help. So those are like, I mean, getting back to this idea, if our scheduling, if of our problem as a healthcare system is really we don't have enough of our providers having the ability to provide service to the patient immediately, which means we have an access issue. Adding a generative AI layer on top of it to tell you that there is no access doesn't help. So I think we are in this like magical thinking where we believe that, oh, this added new thing will transform is actually totally wrong. We have to rethink all of that. And that's kind of the movement we're going to see. I'm pretty confident that we're going to see it's the end of an era in health technology. I think there is a new era that's going to open up where we need to rethink our entire technology stack. Like throwing like small incremental things on technology, adding an AI here, adding a large language models here, adding a scribe here it's not going to provide that value that we all expect. So I think they're going to be this like disillusionment phase where we're going to realize that it's actually much harder. And we're going to understand then that it's harder, but it's possible to drive something different. So I feel like that's going to be the wave I see it.
It's brilliant. I mean, I just think that IT executives, they have to think like in my own, they have to think to themselves in my own life, or let me try it as a patient. Let me try this thing I implemented and see if I enjoy it, right? I've got a complex question about a procedure and insurance and whatever, like let's say, and anyway,
No,
it's
I think one of the key summaries I think you and I agree on is like we need to be product mindset in technology. It's not IT as a project backlog of items we need to deliver to an organization. There is a need for us to be part of what are we doing, and that means like we need to be in a product mindset. So I feel like this is one. If there is one note I would say is like this is what we need to be driving as a technology. Honestly, like this has to be not collaborative. It has to be product mindset. I think we use the term collaboration a lot. If collaboration it ends up being a waterfall process where it's a project-based approach, there is no collaboration doesn't help much. Collaboration in the true sense means we are rethinking how we deliver this entire thing and we drive that.
And that makes me think of a concept of value streams, where you kind of start with the customer, and you say I'm a customer, and you come up with a use case like I'm a customer and I need to do X with your organization. Take me through from beginning to end, right? That process, and let me show you where the gaps are in your process, where I get dropped as a customer, because I'm between two buckets of your operations and two buckets. I always think of it like when I was a little kid, you used to stack up dominoes and then knock them all over. Well, what I think a broken process is one where they're too far apart at some place. The domino falls down, doesn't hit the next one. That's a broken process. That's a workflow problem. Sometimes going with value streams will help you see it finally from the customer's point of view. They're probably all over in healthcare, right?
Yes.
These gaps, these things where things fall through the cracks.
I mean, I have on my desk, in addition to clinical books, I have like the design sprint, and the team topologies. Like team topology is exactly where the value stream construct came from. Like those are like rethinking how we operate. I think that's the most important thing. I mean, my hope is you mentioned generative AI and the new wave. My hope is that it's gonna lead us to rethink how we operate as a healthcare systems where technology is a cornerstone. Like we see
Yeah.
that happening everywhere.
Yeah.
Technology is becoming part of the key aspects of where the healthcare system think about what is the next phase. I
Yeah.
think that's going to be the next wave, and I think it's a really amazing time we are living in. Like it's going to be an incredible opportunity. I think we have amazing opportunity, and we have to seize it. I mean, there's the other aspect. I don't believe like we are the driver as healthcare system. We are the driver of the care delivery of the entire industry. So we have this accountability. No one is going to come and save us, so to speak. We have to do it.
I love that. That's a great ending, Malik. This was wonderful. I want to thank you so much for your time, and I'll definitely catch up with you at the forum.
Yeah, thanks, Anthony. We'll see the audience there, and thanks again for inviting me. It was
All
a
right.
pleasure.
Have a great day. Thank you.